Okay, now we are recording. So in case you want to re-listen to this, you could do that. I would die of boredom if I have to listen to myself twice, but in case you're not able to attend one of these online sessions, there's going to be a recording of each one, an MP4 words and pictures posted on Blackboard. And so there's that. But yeah, I mean, this is not going to be I'm not putting out some kind of a difficult assignment here. I'm not going to put out a detailed, like, here's how I'm going to grade it, right? I want to see some thought, and I'm a pretty good judge of whether you're thinking or whether you're just saying something to get it done. And it's a one-liner. I don't want a one-liner. I don't want a dissertation, but I want a thoughtful little, oh, I guess I could teach this person how to slow their breathing down, or warm their skin temperature up, or something that you could actually do that's really pretty easy. I could do sleep hygiene. You'll know what sleep hygiene means. So anyway.
Are these going to be on Blackboard?
Yes.
Okay.
Yeah.
When will they be due?
Well, due, let's say, yeah, I should probably close the discussion forum to further posts when I put up the next one. So I suppose due before the next lecture.
Are we supposed to reply to other students?
You can if you want to, if it's nice. So don't be mean. But yeah, you can. If you see something, you want to say, wow, that's just really a good idea. Or you want to say, you know what, I've tried that, and that actually seems to work pretty nicely. Yeah, you can reply. I mean, you'll see each other's posts. Basically you're going to get full credit from me if you say something that to me seems like you thought about it a little bit. And yeah, by all means, look at each other's posts and have a little fun with it. I've generally seen really good online discussion forums when people do that and start interacting that way. It's a different world, but it works. Okay, so clinical psychophysiology. It's a couple of ideas. The way I learned psychology many years ago is that there's these psychological issues. There's psychological stuff, like anxiety disorders and depression, and maybe some behavioral stuff you can do for ADHD. There's psychotic disorders, there's sexual dysfunction, there's addictions, and these are kind of things that psychologists or counselors of whatever ilk, whatever you want to call yourself, whatever your licensure board calls you, you're practicing what I call practicing psychology, right? And this is what you do. And then there's things that you go to a physician for. So you go to a physician for whiplash injuries and surgical pain and fibromyalgia and autoimmune problems and blood pressure and epilepsy. And these are sort of like physician things, at least they were when I learned it. And kind of similarly, I learned a lot about being a facilitator, like Carl Rogers, client-centered therapy on becoming a person. And by the way, you should probably read both of those books if you haven't already, on becoming a person. And well, both anything that Rogers did or said is really sterling material, except that it takes too long to do it. But it's nice. So you have to do it. You have to start there. But facilitator, this idea of accurate empathy, this is a Rogerian term, where you let yourself into what the other person's actually feeling, and you separate that out from what you're feeling as a result of what they're saying. But accurate empathy, it's a beautiful idea. Acceptance, be a good listener and offer encouragement, try to help encourage flexible thinking, access family resources, community resources, be a better advocate. The my takeaway from all of that was that whether it's explicit or implicit, the client tends to be, you tend to expect the client with your facilitation to come up with their own problems, to come up with their own solutions to the problems that they're trying to cope with. And that's a nice idea. Now, surgeons don't do that. You go in with a sore knee, you limp in, and what they do is they put you in an MRI machine, find out what the heck's wrong with your knee, knock you out, cut open your knee, and fix it. And then you're done. So there's a level of practice that you should be skillful at that is equivalent to what the surgeon does. All right? Milton Erickson and Jay Haley are famous therapists, and they're both dead, but Milton Erickson, whether you know his name or not, has been a profound influence on the entire practice of psychology for decades. Jay Haley, interesting character, family therapist, but they used approaches that are much more surgical. And in fact, when you do cognitive behavior therapy, you're using more of a surgical approach. You're teaching assertive skills, right? You're not listening to the person and supporting them until they finally invent assertive behavior, I hope, right? What you do is you listen, and if you end up after a session or two hearing that this is a person who just doesn't know how to assert themselves, they don't know how to stand up for themselves, they're a doormat, they don't know how to, or they don't know the basic mechanism of saying what's on your mind, then my opinion, your job is to say, you know what, I want to go over something with you. I want to show you something that we call assertiveness. And you say, don't ever use this technique unless you want to improve a relationship. And I'm very serious about that. That's also a very Ericksonian kind of a stunt to pull. But don't use this unless you want to improve a relationship. And so here's what you do. There's only 3 pieces, right? Look, you say, here's what just happened. Here's what you just did. You walked into my office and you smacked your hand on my desk. Anybody who isn't really out of touch with reality will not argue if you tell them exactly what they did. If you say, you walked in here and act like a jerk, that's not being assertive, that's being aggressive, and people will argue with that. But if you say, here's what just happened, here's what really objectively just happened with no judgment attached, that's a very nice beginning to being assertive. And then you say, here's my reaction. I want you to know my reaction. I thought to myself, oh my goodness, is this guy going to hurt me? Or I felt startled. So either here's what I thought or here's what I felt, right? And then number 3 is the assertion. Here's what I want. I want you to explain why you're so upset that you smacked your hand on my desk. Huh? So that's assertive behavior. So when you teach someone that and you have them practice it, you don't get something just because you heard it once, right? But you have somebody practice it. What you're doing is you're installing a new pattern that's really going to work for this person. You're doing the same thing when you teach reappraisal, listening skills, relaxation skills, problem-solving skills, or even maybe sometime some of you will end up using operant conditioning to modify the brain oscillations, which will modify the person's internal state of mind and body and emotion. That's called neurofeedback, or other biological signals, whatever you're doing. So when you're getting somebody to practice something specific and you're predicting that this is going to change their life, that's why you're doing it, that's more surgical. You get that? Anyway, so I think in practice you have to gracefully move back and forth between both kinds of stances. Think of these as different stances. wanted to give you just a couple little examples and you can read through these things, so I'm not going to belabor it. But when I talk about clinical psychophysiology, what I mean is doing things about like what people are eating. I make dietary nutritional recommendations all the time. I find to my distress that the physical medicine people do not do this. I don't know why they don't do this. But by and large, they don't. Some do. You know, I have a wonderful behavioral pediatrician out in Chanhassen, who most definitely, or Chaska, wherever it is, definitely do it. But not too many psychiatrists or primary care physicians or pediatricians have much to say about diet and nutrition, and they should. And especially if you want to read about why they should, read this article on this link. If you have a lousy diet with too much simple carbohydrates in it, you're feeding bacteria in your gut that will actually cause inflammatory disorders, that will cause anxiety and cause depression. Yeah? So eating comfort foods, so-called, is not just a sign of you know, like you're stressed out and so you're going to food to try to calm yourself down. It also causes you to become stressed out. So it's a cycle, and it's a vicious cycle that you need to know about and you need to break. But that's just one example of what I mean by clinical psychophysiology. Another example involves sleep. And a lot of people that you will see have sleep disorders. A whole lot of your present and future clients are going to have trouble falling asleep. They're going to have trouble staying asleep. They're going to have restless, non-restorative sleep. You need to know about sleep. And I have a nice lecture on that for you later. Now, this is very unfortunate situation, but people are still being prescribed so-called sleeping pills, right? Drugs that cause sedation. They're called hypnotics as a class. Ambien, Lunesta, Sonata are the newer ones. Temazepam, benzodiazepine is the classic, and that's still prescribed like candy. And see, the only trouble with using drugs like that is that they increase your risk of disability or death by some really, really distressingly high numbers. And they don't work very well either. So if you look at like this, even if you just look at this last link, it's a rundown of this whole deal. And frankly, I'm guessing you probably haven't heard of this. Maybe you have, but there's some astonishing data from very large case control studies. And by very large, I mean you take 10,000 patients who are taking benzos, and you take 20,000 who have similar risk factors, similar patterns, age, sex, weight, risk factors, smoking history, overweight, and you match them. It's called case control study. It's how you do epidemiology. And what you find out is that over a 4 or 5 year period, the use of benzodiazepines, including the new benzos, which are Ambien, Lunesta, and Sonata, and they're not really benzodiazepines chemically, but they do exactly the same thing. They attach to the receptor for GABA, which is the inhibitory neurotransmitter, and jack it up. People taking these things have anywhere from double to 5 or 6 times the risk of heart attacks and strokes and all-cause mortality. This is not a small effect, it's a huge effect. So I want you to be aware of that, and we'll talk more about it at another time during the sleep lecture. But check out some of these. They're really quite quite remarkable in their associations. And of course, the drug company spin doctors immediately came out and said, "Oh, well, that's just a correlation." And tell you what, when you got correlations of 5 or 6 times the death rate in a population of 10,000 people that are followed up for 5 years, that's not just a correlation, right? That's what the tobacco companies said, and they lost that one big time. And so someday there will be a class action suit about this, I hope, anyway. So anyway, that's just a couple of quick examples of how you use this stuff. Problem with diagnosis. There's 2 problems with diagnosis. One problem is the unfortunate situation with the DSM. Are any of you aware of what the director of the National Institute of Mental Health said about the DSM-5 3 weeks before it came out in 2013? Anybody? Okay. What he said is that the DSM has no validity. This is the director of the National Institute of Mental Health, Tom Insel. I'll show you what he has to say at another time. But yeah, so the problem is that your DSM diagnoses are all symptom-based labels. Okay, get that very, very carefully and very thoroughly, because it's deeply, deeply important that you understand that, and that you be able to explain that to your patients. Your patients are told that they have depression, and that's why they're depressed. Your patients are told that they have ADHD, and that's why they have trouble concentrating. The reason that they have trouble concentrating is not because they have the label that you gave them or somebody else gave them after they told you that they have trouble concentrating. Think it through. So this is the problem of validity, and the DSM doesn't have one of those. If you go to a physician because you ran up a couple of flights of stairs and developed a heavy crushing pain in your chest, what's the physician going to do? Anybody? You present at the doctor's office and you say, I as soon as I start exercising, I get, 5 minutes later, I get this heavy crushing pain down in my chest, and sometimes it radiates down my arm. What does your physician do?
They'll put you on an EKG machine.
Makes an electrical measurement of what your heart is doing.
Yep.
Because she is suspecting that maybe your heart isn't getting enough blood when you exercise. And so things might not look right electrically with the heart. In other words, they do some imaging. They may take 3-dimensional echocardiograms to look at the physical structure of the heart and watch the valves flap around. They may do a more invasive arteriogram where they squirt radio-opaque dye into your arteries and they watch how it circulates through your heart. They will find out why your chest is hurting. And what they won't do is they won't tell you that you have chest pain disorder, heavy crushing subtype. Not going to happen, right? And yet, you have somebody who says they can't sit still and they can't concentrate and they constantly get distracted either by their own thoughts or by outside noises or movements. and have trouble organizing. And sometimes they're impulsive and they shoot their mouths off and they didn't mean to. And lo and behold, on the basis of those symptoms that the patient told you about, you've been taught to say, aha, you have ADHD. And that's why you have these problems. And then everybody's happy except for the patient who has no idea what that could possibly mean. Where is the ADHD? And is it in my foot, in my brain? How do you know? Because of what I said? See, so that's what Tom Insel meant by there's no validity to these diagnoses other than as a label, and they're a convenient label. I don't have a problem with convenient labels, but the DSM diagnoses are not scientific diagnoses at all. They are labels for patterns of complaints, which is fine, as long as you know that you're labeling a pattern of complaints, and as long as you know that that label does not tell you anything about why this is happening to this person. You are not depressed because you have depression. So make sure you understand that. It's critically important. And there is a valid way to find out what's going on. And I should have mentioned, like, one of my goals in this course is to kind of help you be a little bit more worried. You can get some stress management, you'll be fine, but there's a lot to worry about. One thing to worry about is whether you're actually looking at some kind of a psychological disorder or whether you're actually looking at some kind of a medical disorder, because there's a ton of medical disorders that create symptoms that sound just like the stuff in your DSM. Yeah? Like all of these, just to name a few. Hypoglycemia, diabetes, hypothyroidism, congestive heart failure, sleep apnea, chemotherapy, cancer. These all create symptoms that look for all the world like some kind of a combination of ADHD and depression. Low energy, loss of interest in things, sexual dysfunctions, more increased or decreased sleep. It goes on. There's a huge number of medical problems that completely mimic so-called psychiatric problems. I had a woman, I treated her for a brain injury, and I don't know, I want to say 5 or 6 years later, she showed up again. And she said that she was having trouble concentrating and trouble remembering stuff. And I thought, well, okay. Usually when I treat a brain injury, it works to restore probably 80% of functioning if it's a mild to moderate brain injury, and it does, and it lasts unless you get another brain injury. So, but people get depressed or whatever. So I'm talking to her, interviewing her, and she had a daughter, lovely girl. She was in college by the time I saw the woman the second time, and I asked how her daughter's doing because her daughter came in for some stuff too. And she said, well, she's been doing great, but I don't know, this fall, I mean, she's a sophomore and she's complaining, a sophomore at a local college, she's complaining about having trouble remembering and getting kind of foggy headed too. And I went, oh, wow. Is she living at home? Yes. Okay. What's the probability of mother and daughter falling into a depression bad enough that they're going to have trouble concentrating and remembering stuff? Not big. So, so what I told her is I said, I want you to go to a hotel tonight. Right away. Promise me you're going to sleep at a hotel tonight. Oh, and if you're going home this afternoon, it's October, it's getting a little bit cool, but open the windows and then find your way to a hotel. Why did I tell her that?
Was it a gas leak?
It was a cracked manifold. I told her to get, carbon monoxide coming out of her forced hot air furnace. I told her to get a furnace guy in immediately. Somebody showed up the next day, found out the manifold, the heating, the thing that the gases go through that heats the air up around it, it's cracked. So she and her daughter are getting carbon monoxide poisoning. So that's what I mean by worry. If it's the heating season and you see somebody who's got new symptoms of memory problems and concentration, it's one of the first things you ask them. Right? October through now. Anyway, lots of stuff to worry about. Just a couple of the diagnoses I use. And by the way, you all know about the ICD-10, soon to be ICD-11, International Classification of Disease. That's what the rest of the world uses instead of the DSM. It's also what contains the billable diagnoses that you make if you want to bill for your services. So shortly after the DSM-5 came out, all the insurance companies switched over to requiring ICD-10 diagnoses. So you do not use DSM-5 diagnoses when you bill an insurance company. If you don't already know that, now you know. So that's all I use. I don't use the DSM at all. And the ICD-10 psychiatric diagnoses, really, a lot of them aren't any better, but that's what you have to use for billing. So you might as well know that. Get the book or use the online free version. I just put this up to mention some of the diagnoses that I use and that I don't want you to miss. So when you make a diagnosis, you come up with something that best describes the symptoms that the person has got. And but one of the things that I find psychologists and counselors often neglect is diagnosing everything that's there. And so insomnia, you want to find out about sleep. You want to find out all about sleep and how long it's been bad. It usually poor sleep usually precedes major depression. It's usually coincident with anxiety disorders. But you can often diagnose insomnia of some type, and there's a few different types that are mentioned in the ICD-10. You can look at the link. But it's a good idea to diagnose what's there. Don't make stuff up, but don't neglect stuff, because if you can make 3 diagnoses that are justified by the symptoms, you're going to have an easier time with the managed care people, right? Because they're not going to argue with you. I haven't had a discussion with a managed care person and I don't know how long. I mean, like 15 years plus. I don't know, long time, because they got to know me. The companies know me, I guess, but they don't bother because I know what I'm talking about, and I diagnose what's there. And so if you just diagnose an adjustment disorder with depressed mood, you should be able to get that done in like 6, 8, 10 sessions. So if you're still working with the person 20 sessions, somebody might call you up and say, "Hey, what are you doing? What's taking so long?" And but if you show them, up front, we're dealing with a few things here. You got insomnia. You got a depressed mood that's probably an adjustment disorder. But this person also has pain, and they don't. And it disrupts their sleep, and it distracts them in the daytime, and it's very depressing because they've been through 3 courses of physical therapy, and they've really not gotten effective relief. and they're getting agitated because they're in pain and they're feeling like their physician isn't taking good care of them, and they don't know what to do about it, and they've got a lousy exercise pattern. Their posture is tense. They're all, guess what? They've got F54, psychological and behavioral factors associated with disorders or diseases classified elsewhere. So this is one of my favorite diagnoses. I use it a lot, and I just want you to know about it. Sort of read about it. Pain disorder with related psychological factors is the ICD-10 code. Let me see if this thing comes up with it. Now, are you still seeing my PowerPoint, or did it switch over to a website?
PowerPoint.
Okay, let me switch it over to this because it's worth looking at. Where did it go? Is that it? Yeah, ICD10data.com. So in it, you type in pain disorder, and you see these, or you type in whatever you think they've got, and it'll put up things that maybe fit with it. And what else it does is you see this little I don't know, this little thing right here in between the diagnosis code and the convert to ICD-9. I don't know why that's there, but right in between that is this little thing, and if you put your cursor over it, it'll light up billable/specific code. And that means you can bill it and you might get paid for it. So this is a very, very handy gadget. And it's fun, it's easy to use, it's free. And I suggest that you bookmark it, ICD10data.com. And just so you have an appreciation of how thorough the International Classification of Disease people really are, this is my favorite ICD-10 diagnosis, which is drowning and submersion due to falling or jumping from burning water skis. Sequelae. Well, this is the original. This is the first time you see them. It's a V90.27, drowning and submersion due to falling from jumping from burning water skis. So just in case you drown, I don't know how you have a sequelae. I thought drowning meant dead, but maybe you can be resuscitated. If you ever jump off of your burning water skis, just rest assured that there is a diagnosis for the problem in the ICD-10. So back to the PowerPoint. So anyway, get familiar with these kinds of diagnoses. You know, as a counselor, you might not think of diagnosing a pain disorder with related psychological factors, but if you got somebody who's complaining about neck pain, right, or headaches, you say, well, where does your head ache? And they say, and they're sitting there looking at you, and they say, it hurts here. And you go, oh yeah, I can see your forehead looks kind of tense. Just relax your forehead and let's see how that feels. And they go, okay. Okay. They're not relaxing. If they don't know how to relax, that's a psychological factor. It's causing pain. You got F45.42. Write it up on your diagnostic. Okay. That's how you use this stuff. Okay. So, and if obviously you're all at home, So take a break when you need to. I'll do the same. I want you to know the autonomic nervous system. This is peripheral. It's called peripheral. It really starts in your brain, so it's not really peripheral nervous system, but a lot of it is in the body, so it is peripheral as opposed to central nervous system. It's out here. It's this autonomic, which is just a word for automatic system, and it's designed to cause you to be able to have the best chance of surviving. Something's gurgling. There. Short-term survival and long-term survival. If you get both, then you get to live long and prosper. But the short-term survival specialist is called the sympathetic nervous system. The long-term survival system is called the parasympathetic. Now, it's never just one or the other, and they exist in a dynamic balance. They're constantly shifting around. When you're more challenged, when you're more excited, when you're more activated, you're more in the sympathetic mode. When you're more placid, when you're more just kicked back and you don't have anything that you really have to do, you're more in the parasympathetic mode. The sympathetic mode provides a very, very fast response to a dangerous situation. It's not just fight or flight, though. That's a misnomer. It's challenge, but it is designed to fight or to run for your life. So it is fight or flight, but it's also just challenge. I mean, you activate your sympathetic system if you're lifting weights, if you're running, if you're biking hard up a hill. When you're just cruising down the hill, just rolling, that sympathetic excitement drops down and you go into parasympathetic rest and restoration. There's very different things that happen physiologically. When you're in sympathetic arousal, your hands get a little sweaty. Right? That happens whether if you're nervous about getting up on stage and doing a presentation. It happens if you're lifting weights. It happens if you're riding your bike hard. It happens if you're meeting somebody and you're uncomfortable with yourself. But it's a sign of sympathetic arousal. Reason evolutionarily, probably the reason is that if your hands are a little bit damp, they're actually a little bit stickier, right? And if they're a little bit stickier, you can probably throw a rock, bash something's head in with a stick, throw a spear, climb a tree, climb the rocks. You got a little more traction. That's probably what it's for. Also, when you're in sympathetic arousal, your blood flow gets shifted toward the muscles, toward your large muscles. And you only have a certain amount of blood. And so the blood comes from somewhere. Where it comes from is the blood vessels that feed your skin, right? And the blood vessels that feed your gut, your digestive system. So when you're, and to some degree, the immune responding to, so these things get turned down when you're challenged, when you're in a respond to challenge state, your immune system gets shut down. The blood flow to your gut and to your skin gets shut down. One thing that does is it shuts down your digestive process. You also get changes in the brain blood flow, and your brain actually goes into a simpler state. When your arousal goes way up, your brain is only going to do more simple thinking, like run for your life or bash its head in, depending on your preferences and skill levels. See, so that's pretty simple thinking. When you're in this long-term survival mode, in the parasympathetic state, that's when you get digestion returning. That's when you get peristalsis in your gut. That's when the food gets digested. That's when your blood flow goes back to your skin. That's when repair and restoration happens. And that's also when your thinking becomes more complex and creative. So you need both. I want you to make sure that you really read these and study these, because these are incredibly important. Your hands get warmer and drier when you're in the parasympathetic mode, because the blood flow has come back to your skin. Your hands dry off gradually, right? Because you're not in a defense alarm state. Your breathing tends to slow down. Your heart rate slows down, and also it becomes more variable, which is, we'll get into that in the second half of the course, actually. But you get increased heart rate variability when you're in a calmer state. If you want to know more about that right away, Google heart math. Heart, M-A-T-H, heart math. It's a company, they sell a heart rate variability gadget that's really pretty lovely. It's for home training. It costs about $100, plugs into your iPhone or Android. Anyway, sympathetic arousal, your hands get cooler because the blood flow goes away from them. Your hands tend to get more moist. You tend to breathe with a shallower, more of a chest breath. Oops. Your heart tends to beat faster. Your blood pressure goes up because your heart's beating faster, but also because there's less place for the blood to go, because you just shut down a lot of the blood flow to the skin and to the gut, and those are two major places for blood to go. So if you kind of close them down, there's less space, the same amount of blood, the pressure goes up. Muscle tension, ready to do something. Loss of appetite, you get into a fight before dinner, you're going to lose your appetite. Sometimes excess, but that's probably a psychological compensation. And feeling hurried and irritable and sort of hyper-competitive, these are all signs of being in a challenged state, right? So you need to be able to identify those, at least subjectively. At the very least, if you meet a new client and you shake their hands after the virus is over and everybody has their vaccine, you shake their hands and it's cold and damp, something's going on with that person. Make a note. Anyway, I put this in here. I used to, in the old days, when I did this course live, I handed out these cute little thermometers so that you could actually see this happen. It's quite dramatic. In the syllabus, I suggested that you get yourself a thermometer, and specifically this thermometer. Did anybody actually happen to get this gadget? Anybody? Okay. So next week, have one of these. This goes for I think about 10 or 12 bucks. $11.42 on Amazon. Now, hopefully you just spent more than that on your book. And you certainly spent more than that to sign up for this course. So, yeah, I want to suggest that it'd be good for you to get one of these. All right? And this, I'm trying to make this an actual clinical course. If you've had some clinical courses at the school so far, you may have noticed yourself doing things like a therapy session, basic counseling skills, right? Doing active listening. The only way to learn stuff is to do it. Hearing me talk about it, you'll be lucky if you remember it long enough to take the midterm and get that question right. And so then taking this course will become completely pointless academic exercise. So get yourself a thermometer. And the one I'm suggesting is the Taylor thermometer. It's a nice gadget. It's for 12 bucks. You could actually use this professionally to do skin temperature biofeedback training. It measures that little thing down here. It's a wire. It's meant to be an indoor-outdoor thermometer where you stick that probe out the window to measure the temperature. But what you actually do with that probe is tape it. You go to a drugstore, put your mask on, and go to a drugstore and get yourself some paper hypoallergenic adhesive tape. And you wrap the probe of this thing, right? You wrap the probe onto your index finger, right? And you'll lightly tape it on so that it's stuck onto your index finger. Try your left hand first. If you actually wanted to do it for a clinical purpose, you probably want to do it on one finger and then the other hand and move it around. But get the thing, tape the probe to your finger, and sit there for 2 minutes with the probe. And this is a little psychophysiology technique, right? Because psychophysiology is science, and science depends on accurate measurement. You need to be measuring what you think you're measuring. So you tape this thing to your fingertip lightly, so you're not squeezing it so hard that you're restricting blood flow, but so that it's on there. And then you want to put your hand, if you can see my hand in the little window there, put your hand on something so that your finger's up, so that it's not touching anything. You want it in free air, right? Because if you put it on if you rest your hand on your computer, you're going to be taking the temperature of the computer and your skin, and it's the arm of the chair. Don't put it on your leg. Don't rest it on your belly. Because what you want is you're trying to get an accurate measure of how much blood is flowing in your skin. So that's what's causing the temperature to go up or down. So you sit there for 2 minutes and let it equilibrate, and you'll see some kind of a number show up on the screen. And it might be 85, it might be 90, it might be 88.2, whatever it is. Write it down. Then you sit there and close your eyes and take the demand off of yourself. Anybody ever practice any kind of meditation?
I like to meditate.
Okay.
We do it in DBT at Practicum.
Oh, okay. Okay. What kind of meditation do you do in the DBT practicum?
It kind of depends what we find. We just did a COVID-19 one. That was interesting.
Okay.
We just find something with relaxing music and a voice that kind of does a guided meditation.
Oh, okay.
So it's usually pretty guided, and then it just kind of lets the clients kind of let their brain focus on whatever's prominent in their minds.
Okay.
Sometimes they stay on topic with the COVID-19 or whatever the theme of that guided meditation is, and sometimes people's mind wanders off into different directions. So it's
okay. Well, COVID-19 would not be on my short list of recommended stimuli for meditation.
I thought it was actually kind of helpful, and we got pretty good feedback on it because it was more about relaxing at home and trying to find ways to feel relaxed at home when you're during the stay at home.
Okay.
Oh yeah, it's not sitting there going, what does the crown of the coronavirus looks like, and how
I
many
was just picturing,
evolutions?
if you were really good at meditation, you could in fact meditate on the words COVID-19 or anything else, but it's not the easiest thing to start out with. So Well, here's what so what you do, and you all, by the way, should know what meditation means. You should all know the difference between meditation and guided imagery, and those are not the same things at all. And you should all be practiced in using a meditative technique yourself to create a relaxed, to trigger your own relaxation response. And if you don't know how to do that, on my home planet, you would never, ever get a license to practice psychology or counseling. Not going to happen. Because you need to be able to teach people this stuff. And you cannot teach what you cannot do, okay? So make a plan during the course of this course. If I had a way to test you on it, I would, but I don't, so I won't. But make a plan while you're taking this course to begin practicing some kind of meditation, okay? Any kind, I don't care what kind. But I want you to take it seriously. You need to know how to do meditation. Meditation happens when you rest your attention on something that isn't challenging, okay? That's different from guided imagery. Guided imagery is usually programmed by somebody else, and you're invited to follow along a story, right? And so it's also known as hypnosis. Although the people who sell guided imagery don't call it hypnosis, it is hypnosis. It's not hypnosis. And that's one of my, I did a lot of hypnosis in my graduate program and since. So, hypnosis happens when you get somebody to follow along a storyline. Meditation happens when you get someone to simply rest their attention. I like the term rest, right? On something that was going to be happening more or less anyway, or you could make something artificial happen. You could say the word one over and over and over again to yourself silently. You could say any other uncharged word or phrase over and over again. That's called a mantra. Om mane padme hum. It's an old Sanskrit mantra. You could say whatever you want. You could say cheese over and over again, and that's a mantra. You could watch yourself breathe. I like to call it walking alongside your breath. Right? Just watching the breath. Don't control it. Just watch it come in. When it feels like it, it goes out. You'll notice this. Just let it breathe, and you just watch it. It's very, very relaxing. Or you could watch an imagination. So, I could go up to the Knife River and sit on a sun-soaked rock late in the afternoon and listen to the river and watch the sparkly water flowing by in my imagination, or preferably in real life. I like to do that too. But, so you could just imagine you're in some pretty place and taking in the sights and sounds. So I don't care how you do it. Get a thermometer taped to your fingertip. After a couple of minutes, see what the temperature says, and then close your eyes and do some kind of meditation for 5 minutes. If you're able to, do it for 10 minutes. If you're not able to practice a meditation for 10 minutes, ask yourself why that is. And then, after 5 or 10 minutes, take a look at the thermometer, open your eyes and see what it says. And you might be surprised at what you see. I invite you, it doesn't take a week to get Amazon to send you one of these things. So I invite you to tell me and the group what happened to your skin temperature when we start next week. This is when I usually take a break. Yeah, I think I'm going to take a break for just a moment, And I'm gonna go get a drink. I'm thirsty. Yeah, well, that's better. So, hoping everybody or most everybody is still there. This piece of tonight's lecture is intended to be conceptual, right? So take it as such. Don't have to take a lot of notes. I'm not going to ask. I can't think of questions to ask on the test about this half of this lecture, but it's important conceptually. So take it as such. Key concepts. To understand how the central nervous system works, you have to understand that the idea that there are excitatory influences and there's inhibitory influences. And they have to be balanced. And they're constant, it's a shifting balance, right? But there's a homeostatic equilibrium that gets gets built. And when you see disorders, a lot of the time, what's happening is that there's a imbalance, not of some chemical, like your patients are told, oh, you're depressed because you have a chemical imbalance. That's BS. There's no evidence for that. You'll read about that later. But there is an imbalance, but it's imbalance on a systems level where there's just chronically too much excitement. You're spending too much time in the sympathetic mode, or you're spending too much time in the parasympathetic mode, either of which will get you into some kind of trouble. So that's a concept. It's an idea. Another idea is this idea of that our functioning depends on the rapid formation and dissipation of temporary networks. Everything that we do requires more than one piece of brain to do it. Like right now, I'm talking, and I can actually understand what I'm saying. I hope you can too, but I can understand what I'm saying. And that's because I'm generating words in a chunk of my brain right around here. And this piece of brain is networked tightly with a piece of brain right about here, up behind my ear a little bit. And this thing is the piece of brain that is required to understand human speech. And not only that, I'm using different tones of voice, not to mention gestures. But my tone of voice is being generated over here. And this piece of brain has to be listening to what I'm saying so it knows what kind of tone of voice to hook onto it. And this piece of brain on here, back here on the right side, is interpreting my tone of voice so that I understand the tone of voice that I'm using and what it means. So that's a network. And it's invoked every time you shoot your mouth off. You know? If it doesn't work, you have problems. If you whack your head, or if you even slosh your brain around inside your head from a whiplash injury, you may have trouble connecting that network, hooking it up, and so you may have word finding problems. If you have a stroke that affects this piece of brain up here, you can have big time word finding problems, right? If you have something happen back here, you might not have trouble finding words, but you're going to have trouble understanding what they mean, which is very awkward if you say stuff and you don't really get what you just said. This can happen. So anyway, that's a concept. It's an idea. I mean, the whole thing has got white matter, passive, insulated axons connecting all these pieces of brain, but they're always physically connected, but they're not always working together. Like, if I'm doing a math problem, I don't talk, and I don't use this verbal network. I use the math network. It's a different network. So every detailed little different thing that we do requires different network to be set up temporarily. And the way that those networks get set up is by synchronizing the oscillating activity of the brain, the electrical oscillating activity of the brain. That's what actually causes what's known as functional connectivity. So it's a concept. There's a hierarchy to things. You know that. The cortex is on the surface of the brain. Underneath that is the midbrain structures, which are very different from the cortex, and they're often, but not always, dominated by the cortex, although they may dominate the cortex, depends on what's going on. But there's cortex, there's midbrain, there's brain stem. So it's a hierarchy. There's also a laterality. There's lateral organization in the brain. So these are concepts. We'll talk more about those as we go along, but just understand, there's the left brain does something different on the average than the right brain does. Now, don't make the mistake of thinking there's such a thing as a right brainer or a left brainer. There isn't. Everybody has two brains. They're squashed up against each other. They're kind of flat in the middle. That's a brain, right? It's a model of a brain. It's actually a plastic casting of a real brain. But this is the left hemisphere, and it ends right here. It's got this massive plug-in to connect it to the right side. There's the brain stem. There's cerebellum, midbrain structures. Anyway, there's a lateral organization and there's a hierarchical organization. Feedback loops that have base rates of firing. I usually do that on the board, and I haven't used the whiteboard on this thing yet. So just understand it on this level. Just understand it on this level.
If you guys are not speaking, can you mute
brain-
yourself? Yep, I can hear him.
Where am I hearing that from? It's my next door neighbor yelling. So these oscillations, these oscillations that reflect groups of neurons that are being shoved toward a state of high excitability where they're very easy to talk to, and then they drop down, and then they come up, and then they drop down, and then they come up. So there's kickers, and they're in the thalamus. They're in the middle. I don't know if you can see this thing right here. That's the thalamus right in the middle. And among its many, many talents, it has these little oscillators, these little groups of cells that constitute electrical oscillators, and they drive cortical neurons in rhythm. Some very fast rhythms, but all of these rhythms are what gets these different pieces of brain to be excited at the same time. When they're excited at the same instant, then they can talk.
Sure. Hey, John, you, I think, have the power to mute the microphone that is creating all that noise. Can you mute Wada's? Because I'm pretty sure it's coming from that one.
Yeah.
Somebody talking.
Yeah, it's Wada's. He's lighting up whenever
Where that's coming
we get it.
I'm sorry.
Oh my gosh.
I don't know how much of the lay neuroscience literature you may have come across. The stuff's been published everywhere from Psychology Today to the New York Times to the Star Tribune. It's been around for a while. It's pretty interesting and useful stuff to understand. One of the ways to measure these networks is that when a piece of brain gets busy, it starts drawing more blood flow. So like literally, because I'm talking right now, if you had a bunch of little thermometers on my scalp, you would actually see this region where I'm generating these words, you'd actually see the temperature go up because of all of the extra blood flowing into this area to support the activity of the brain cells that are making up the words, right? So that was actually done years ago before they developed what's called functional MRI. Functional MRI just means you tune the MRI so that instead of revealing maybe what it usually reveals, which is like bone versus not bone, or fat versus water, which is what you see when you do a brain scan and MRI of the brain. You can also tune the MRI machine to be sensitive to highly oxygenated blood versus not so oxygenated blood. So you can see where the fresh blood is getting dumped. And so when you get people doing a task, there's certain parts of the brain, that you can see this network light up that reflects the task specific network. If you don't give somebody a task to do, what you get to see is their default mode network. And that's kind of an important idea. It turns out, if you stop bothering a person and just ask them to sit there on your MRI machine, they don't just disappear. The brain doesn't just go flatline. You know that. You've just sat there, right? You're not just sitting there unless you're a highly experienced, Zazen practitioner. If you know Shikantaza, which is just sitting, then maybe if you practice that for 20 or 30 years, mostly what's going on is nothing. But an ordinary person, when you're just sitting there, you daydream, you think about stuff, you think about your plans, you think of what you want to do as soon as you get out of the stupid tube that's making this terrible noise that you're in this experiment for. That's the default mode network. It's where you go when there's no demand on you. And you don't go into nowhere, you go somewhere. And it turns out some people's default mode network is a very nice, comfortable place. Other people's is not so nice and not so comfortable. It turns out some people, when you give them a task, when you say, hey, okay, listen, right now, listen up, I want you to do this. Bang, they pop out of their default mode network and they go into a task network at your request. And they'll stay. Some people will stay on a task network easily. Some people, however, fall out of the task-specific network too easily into their default mode network, right? So they're focused and they're thinking about what you're asking them to think about. They're listening to what you want them to listen to. They're doing the work. And then that's so cool. There's this cardinal sitting out on a branch. Whoops, where was I? See, so I went into my default mode network, which is to stare out of the window and look at birds, See, so some people pop out of that task network way too easily and go into a default mode network. Other people have trouble getting out of the default mode in the first place. Anyway, this stuff has been studied a lot, and it's worth knowing about. This is a in case you've never seen fMRI imagery, this is one example. This is a global fMRI. These researchers were interested in finding out what happens when you go from a task-specific mode to the default mode, and then into a different kind of task. So what they did is they had people generating words. Just say as many words as you can that begin with A. And when you run out, just go on to B and go on to C and just keep generating words and words and words and words. So that's a very busy word network. So then they said, okay, we're done with that part. Just lay there and we'll let you know when we want you to do something else. And so then, it lets people lay there for 5 or 10 minutes. They go into the default mode where they're just going to where they usually go when nobody's bothering them. Then these researchers said, okay, now what we want you to do is we want you to say the word one over and over and over again at any speed that you want. We just want you repeating silently to yourself, repeating the word one over and over and over again. Okay. And then they recorded what happened. And what you're looking at with all this blue, the blue areas and especially as that where they shade to greenish. Doesn't look terribly greenish on my screen, but somewhat. What these areas are, and they're very, very big areas, as you can see. What this color scale is indicating is that from blue up to green, which actually gets green in some, pure green in some spots, that's a 3 to 8-fold decrease in the blood flow, which means a decrease in the brain metabolism, which means a decrease in how busy this brain is. It's a huge decrease in the overall metabolic rates that are the rate of burning energy, the rate of blood flow, the rate of the amount of busyness in this brain, or this is a group, this is a group study, so there's 22 people in it. This is a huge drop in activation, say, and this is actually a simple meditation. It's saying the word one over and over again. This is Israelis that did this, so it's a Hebrew word, eshat, but it's the word one. And so if you ever happen to bump into someone who has a busy brain and they can't shut the thing up, let's say they're having trouble falling asleep at night, or let's say even when they're on vacation and they're supposed to be having a nice time sitting on the beach or paddling a canoe, they can't stop worrying about what they're going to have to do when they get home and the work they should have gotten done before they went on the vacation, and they're yammering at themselves. If you could talk them into actually just saying the word one to themselves over and over and over again, their brains would quiet down. If you do that while you're laying in bed and you're already tired, you will not be able to stay awake for very long, guaranteed. The trick is getting a person to do this, because usually my patients, you know what they do? They'll think the word one over and over again to themselves for about a minute, and then they'll start yelling at themselves because they're not asleep yet. So I have to tell them, what I want you to do is I want you to commit to saying the word one over and over again to yourself for a minimum of an hour. And of course, nobody but a highly experienced meditator could possibly do that and stay awake at night, tired from the day, laying flat on their back in bed or on their side. So anyway, a very interesting, really a demonstration of the very, very physiological effects of a very simple meditation. Questions about that? I'm looking around the room. Next time or the time after that, I forget when, I'm going to talk about how neurons work. And we'll talk about excitatory postsynaptic potentials and inhibitory postsynaptic potentials. Postsynaptic means here's the synapse.
We might be doing it
And then it's going to spurt a little bit of a chemical out at that next nerve cell that it's aimed at. And that chemical is either going to make this cell get more excited, closer to being fired, or harder to fire. So it's either going to excite or inhibit the cell. So you call the excitatory, the result of an excitatory neurotransmitter, you call that an excitatory postsynaptic potential, because it's a little shift in the membrane potential of the neuron toward firing threshold or away from firing threshold. Well, these events happen rhythmically, see, and they happen in a lot of cells at the same time. And in fact, They happen all over the brain. And they happen with such synchrony that you can actually see it happening. These are microscopic events, but they summate. You got a lot of neurons doing the same thing at the same time. They actually make measurable little electrical events. All you got to do is stick an electrode on top of on the scalp and compare what's happening someplace on the scalp to what's happening at the earlobes, which isn't usually very much. And you will see little bumpity bumps like this. This is a 19-channel EEG recording of a fairly normal person. I hate to say completely normal because it's a recording of me, but halfway normal anyway. And what you see are this is 1, 2, 3, 4, 5 seconds of time on 19 different electrodes. And you see lots and lots of little bumpity bumps, big, slow waves like these over here. Okay. And you see these rhythmic waves here. So these are all different brain processes that are all going on at the same time. But one thing that's true and common with all these different little bumpity bumps and bigger bumpity bumps is that on the upswing, there's a group of cells that just got hit with a bunch of inhibitory postsynaptic potentials, and on the downswing, that's the result of the same cells getting hit with an excitatory push, and they're just waving in the breeze at different frequencies, right? Getting closer to firing threshold, getting further away, getting closer, getting further away. This is my default mode. Here, I'm just sitting there with my eyes closed with nothing particular on my mind, say. And this is a typical, these waves you may have come across in your searches on the internet for a cure. You may have come across alpha waves. You may have come across meditation or crystals or sound and light machines that flicker and sound and light at you that push alpha. There's a lot of people that sell alpha. These are alpha waves, and 90% of people have a decently visible alpha rhythm. Mine is sort of medium to large amplitude, but this is what alpha looks like. It's just a rhythmic oscillating. It happens around 10 times a second, and it's a sign that the brain in the visual systems in the back of the head, it's a sign that the brain is on idle. Now you don't see much of that in the top channels here, because these top channels up here are recording from the front of the brain, and these are executive systems, and I did not have my executive systems on idle for this recording. With some non-effort, I could put them onto more of an idle, but the executive systems, they tend to stay on. They're supposed to stay on. But the sensory processing systems can go on idle when you're resting. So anyway, that's an EEG. We'll talk more about EEGs later. So now you know a little bit about this idea of network connectivity. So in addition to too much inhibition or too much excitement, right? Too much or too little excitement, you can also have too much or too little connectivity. So functional connectivity is what disorders are made out of, right? Most of the psychiatric disorders are demonstrated. This isn't a guess, okay? Are demonstrated to be associated strongly with abnormalities in the connectivity between different regions. Childhood adversity, childhood trauma changes this connectivity. In fact, adult trauma changes the connectivity between systems in the prefrontal brain and systems in the temporal lobes, the amygdala. The control circuits are up here. Oh my God, I got to get out of here, or I'm going to to bust your head in. That's the amygdala talking. These prefrontal systems are supposed to control that. When you're traumatized, that connectivity gets changed, and not in a good way. Recurrent major depression has been studied, and repeated different kinds of technologies, whole different PET scans, fMRIs, and EEGs have all shown the same thing. People who keep getting depressed have too little arousal on the left front side of their head. They have signs of low levels of excitement in these cell systems. The left frontotemporal circuits, this whole region of the left front brain, is what develops optimistic approach behavior. It's what allows you to look forward to a good time. If only you do this, that, and the other thing, bang, then you got it, see? So that's what you put together a plan with, and it's what you put together this optimistic approach, like I can do this, I can get this for myself, this will be cool. If those systems are sitting low in the water, you're a mark for getting depressed, you're a setup. If something goes wrong, then you'll get depressed. If those systems are normally excited and they're ready to go, if something goes wrong, you fix it. Or if you can't, you find somebody who can teach you how. See, that's optimism. So-called ADHD is complicated. There's 3-4 different common setups in a brain that can cause the same symptoms, which is why you shouldn't just call it one thing, because it's not one thing. But there's an attention network. There is that. It goes from the frontal cortex, kind of up here, into the cingulate gyri, and then back into the parietal lobes. And you can measure this. It's the attention network. And if it's underexcited, you're not going to pay attention very well. You're not going to be very careful. Learning disabilities show up as bad connections in the automatic association areas in the back of your head between the things that you already know and new information that's coming in. See, anxiety disorders, they look like something on a brain level. A real deal anxiety disorder, you normally see too much excitement in the somatosensory systems that allow you to feel stuff, and in the parietal systems that allow you to think stuff and make connections between things, as in worry, and sometimes in the actual temporal lobes and the parahippocampal gyrus and the hippocampus and the amygdala on the right side, you may see that being overactivated, overexcited. And so it's a complicated pattern, but it's a pattern, and you can detect the pattern with relatively simple, relatively inexpensive equipment. So anyway, that's what the National Institute of Mental Health is talking about when they say these DSM diagnoses are not valid diagnoses. The correct diagnosis of somebody with recurrent major depression is not recurrent major depression. You don't get recurrently depressed because you have recurrent major depression, right? You get majorly depressed over and over again because you have hypometabolic left front brain. That's actually the disorder. No, that's not in anybody's book yet, but it will be. So now you know what's going to be in the book before it's written, which is always a good thing. Okay. Any questions about all of that? Everybody's still here. overwhelmed, bored, silly? Give me some reactions.
I'm finding it very interesting.
Same, because, well, at Prairie Care, I do a lot of diagnosing with the DSM, and that's just our standard of practice over there. So I really find this interesting, like from that perspective.
Cool, cool.
Yeah.
And I forgot to put my headphones on. That's why I heard somebody saying something and I missed it. I'm sorry. This is the first time I've used these headphones because I recorded Zoom for the first time today, and I played it back, and the sound quality was so horrible that I just cringed. So I found these headphones, but I just put them back on. So sorry about that. I'm new to this, but good. I'm glad this. I mean, this is. I'm hoping these ideas will inform what you're seeing, you know, in the clinic, and then I'm hoping that you'll take the challenge to actually start using some of these things, right? Use them on yourself first, and then you don't need certification to do skin temperature biofeedback. My apologies to my dear friends at the Biofeedback Certification International Alliance. They sell certifications in biofeedback, and they're very good people. They're lovely, and it's good to get certified in things, but it's so hard to hurt someone by measuring their skin temperature, and it's so easy to do that I don't see any reason. You practice with yourself for a few weeks until you can actually, after you do it for a while, you do it for a week, when you sit down and you start thinking about, well, I'm going to let my skin temperature warm up, which is what will happen if you relax. You can actually feel blood flowing into your hands. I mean, it's weird, but you can actually feel your hands warming up, right? And what else will happen is if you sit there with that for 5 or 10 minutes, you'll feel yourself getting into a more emotionally relaxed, emotionally calm state. And so guess what? If you have a person who's anxious, you put the thermometer on their fingertip and you find out it's sitting there at 86 degrees. When you're completely relaxed, and what will happen is the peripheral blood flow opens up, your skin temperature measured the way I described, just lightly taping this probe to a fingertip, it'll go up to about 94 degrees, okay? Now, if you do get a thermometer and try it with yourself, if it doesn't go up to 94 degrees the very first time that you try it, please don't worry about that, right? If it's already at or close to 94 degrees, don't think you're some kind of hot stuff. Try it under some competitive demand, right? You may find out it goes down. It may not go down very much. Some people, there's individual differences. They're very large. So some people might be sitting most of the time at 90 degrees and they relax, it goes up to 92, 94. Some people in my class, when I've handed out these little cheap 50-cent alcohol-based thermometers that I hand out in class, some people, temperature go up 6 or 8 degrees. I even had one guy who was kind of a hotshot, who, when I started talking about that stuff, he let me know that he already knew this, and he's a hypnotist, and he already knows how to relax, and that's fine. So we did the thing, and see, a lot of I don't ask personally, you know, I don't ask everybody to say what it was, but I just say, you know, did anybody's skin temperature change? You know, and like about 80% of the time, in 5 minutes, everybody's skin temperature, 80% of people's temperature changed. And then I mentioned, well, you know, so when you vasodilate, you relax, you vasodilate, your peripheral arteries open up, and so your hands get warmer when you're relaxed. Okay, this is pretty straightforward. And this guy goes, no. I said, what do you mean? No. He said, my skin temperature went down and I was relaxed. Okay. If your skin temperature goes down, you are not more relaxed. You are less relaxed. You may not know it. You may think you're relaxed. You know, like I'm really good at hypnosis, and you know, so I can actually I'm trained in this stuff. I can dissociate myself to the point where I can't feel my arm. It takes about like 37 seconds. And I can imagine now that my arm is like a feather floating in a warm spring breeze. And wow, it just feels really, really, really relaxed. That's really nice, but it's not. So that's what's nice about psychophysiology, which is that you deal with what actually is. You measure it. You can't measure everything. You know, you can't measure a person's level of equanimity all that easily, but you can measure the skin temperature, and it does mean something. So anyway, there's that. So yeah, application. This is all about applying this stuff. I want to finish up by just saying a little bit about psychopharmacology. Has anybody taken the psychopharmacology course yet? Okay. Whoever teaches it probably doesn't like me, because I have some unkind things to say about psychopharmacology. But I have some kind things to say about it too. So I'm just going to say a little bit about it tonight. Why? So you'll be aware, those of you who are doing some kind of practicum right now, or may also already be aware that the patients you're seeing are somebody's often prescribing some kind of drug for them. And there's a rationale, which is that these drugs can increase or decrease excitation or inhibition. And part of what I want to go into in the next 2 lectures is how cells communicate, so that you get a basic understanding of what these psych drugs are doing, and what the theory behind them is, and what the actuality is. So with the idea that you can help your patients a little bit better if you can help them understand what the drug is supposed to be doing, and if you can help them understand that the drug is not going to cure the problem they've got, and that it may in fact create some pretty decent side effects that they may or may not want, they may not like, but it may, for some people, create some benefits. But it is not a treatment, or in the sense of making a problem go away. And so this is an important thing to understand. It's important to become able to talk about this with patients. You may have heard of SSRIs, right? Selective serotonin reuptake inhibitors. They're sold as antidepressants. And indeed, some people may feel less depressed when they're taking these drugs, but they are not antidepressants. That's from the marketing department of the drug company that makes the stuff. So-called antidepressant, Prozac, Lexapro. These are serotonin reuptake inhibitors. They get in the way when you release a neurotransmitter into a synapse. I'll go over this again. I like to rake you over the coals 2 or 3 times, then you remember it. So I'll be talking about this with illustrations next time. But You squirt some chemicals into a synapse, and they do their thing with the cell they're aimed at, and then immediately, actively, the neurotransmitter gets sucked back up out of the synapse. It's called reuptake. Right? So there's these serotonin transport molecules that pull the stuff right back up out of the synapse. The drugs like Prozac get in the way of that. All right, so they're called serotonin reuptake inhibitors, and they're selective. If they're selective, it's because they only do that to serotonin, or mostly only do it to serotonin. So an SSRI. But the thing is, and that's real, and that's what they should be called. They should be called serotonin reuptake inhibitors, not antidepressants, because they don't work for very many people's depressions, A, and B, they're selling the patients and the doctors and you the concept that there's such a thing as an antidepressant. Now, you're perfectly well aware that there is such a thing as an antibiotic, right? Antibiotic means it kills bugs that are bothering you. Antiviral means that it suppresses the ability of a virus to reproduce. And so an antidepressant must knock down depression. That's the marketing department talking. It's a serotonin reuptake inhibitor, and it can take the bleeding edge off of the feeling like I'm going to burst into tears, depressed state. Okay. It cuts down on the sharp edge of emotions. SSRIs are prescribed for anger, and they'll cut down on the sharp edge of anger. They're prescribed for anxiety all the time. They cut down on the panicky sharp edge of anxious. And they are prescribed for one of these male disorders that people don't talk about very much, called premature ejaculation. Yeah. Some guys, instead of taking the usual American 3 minutes to orgasm, it's right now. You give them some Prozac and that'll stop. In fact, if you have a normal, and this works for women too, by the way, if you have a normal orgasm at a certain amount of stimulation, you take some Prozac, it'll take twice as long. And if you take enough Prozac, it won't happen at all. And guess what? Your patients who are taking an SSRI, they haven't been told that. Oops. So this is one of the reasons I want you to know some psychopharmacology, so that you can warn the patients about the likely side effects of the drugs that they're taking. I don't like drugs, but not uncommonly, I talk, and by the way, I'm well known in the area. I get a lot of referrals from other psychologists and from primary care physicians and pediatricians and friends and family. And what I'm known for is not using drugs to solve problems. Despite that, I talk people into getting their physician to give them a drug. Sometimes. Why? Because if you're depressed and you're upset and you're telling me that you're tearful, and you get tearful telling me this, and you tell me that you're just so afraid of embarrassment, you got a little bit of social phobia, and you're depressed, and you're afraid to go to work because you might embarrass yourself by bursting into tears, because that's what you feel like doing every time anybody says boo to you. You know what? I'm going to tell you, and I'm probably going to call up your primary care physician and ask them if they would be kind enough to prescribe 20 milligrams of Prozac for you later today, because I can cut down that bursting into tears deal with an awfully large percentage of people with a little bit of Prozac. then you can keep going to work and you have one less thing to worry about. You're going to be a little blunted. You're going to not be as joyful, and you're not going to have an orgasm as easily, but deal with it. And then we'll talk and we'll treat your underlying causes for whatever's getting you depressed. And then you're going to taper off of that stuff and we'll be done. And this will take 6 months. That's how I talk to people. Okay. So there's a good reason for drugs in some people some of the time. Unfortunately, they're prescribed as the first line treatment in this country, which is a disgrace. But this country has lots of disgraces going on, if you read the news a little bit. Anyway, so that's SSRIs. SNRIs is norepinephrine reuptake inhibitor. Some do both serotonin and norepinephrine. Others do norepinephrine and dopamine. We'll talk more about that. Common drugs, stimulants, if your kid isn't doing well enough in school, call up your doctor and get them on some amphetamine. It'll do lots better. Or not actually. No evidence of academic improvement in kids with a so-called ADHD with either methylphenidate or amphetamine. Methylphenidate's the dopamine reuptake inhibitor mostly. Amphetamine does both dopamine and norepinephrine, and it's a nasty chemical, and I don't like it at all. And that's one drug I never talk anybody into using. I don't mind a little Ritalin for a little while I fix the brain so it works better, but amphetamine is a nasty substance. We'll talk more about why at another time. You got your mood stabilizers, most of which are actually, except for lithium, are epilepsy medicines. I don't know if you know that, but yeah, the epilepsy medicines, what they do is they reduce the firing probabilities. They're inhibitory medicines, so they make it harder for your cortex, for your cortical neurons to fire off at high frequencies, and you need to be able to do that to have a seizure. See, so if you keep that from happening chemically, then you have 2/3 of the time you can have fewer seizures. 1/3 of the time it doesn't work at all. But these chemicals all have some kind of an inhibitory mechanism going on, and I'll talk about the mechanisms next time. The antipsychotics are there's just not enough psychotic people in this country to make a decent living selling antipsychotics. And so what you'll see is a lot of kids getting prescribed Risperdal or Zyprexa or Seroquel. You'll see Seroquel prescribed for people simply with sleep problems because it has a sedating effect. These are nasty medicines necessary for somebody who has really loose thinking and a lot of drive to do something about it. So sometimes you want to really put a chemical straitjacket on somebody, to put it impolitely, but that's what these are. These knock down these blockade the receptors for dopamine. And so nothing looks quite as much fun. And they blockade some of the serotonin receptors that are associated with creative thinking, which is to say loose thinking, which can be psychotically loose. And that's one of the things, while I'm here. The dopamine, there isn't just one receptor for dopamine. There's like 5, and there's, depending on how you count them, anywhere from 5 to 7 different serotonin receptors. And so when these people teach your patients and mine that they have a chemical imbalance and that they don't have enough serotonin, it's complete garbage. Okay, doctor, which serotonin receptor is involved here? If you don't have enough serotonin and you're giving this person a receptor blocker that's specific to the 5-HT2A and 2C receptors, what are you talking about too much or too little serotonin? It's actually often got nothing to do with the amount of serotonin in the synapses, and it may have everything to do with the number of receptors of a particular type, right? For example, if you could selectively blockade the D3 dopamine receptors, you would stop 50 to maybe 80% of all relapses into chemical dependency, because that's the D3 dopamine receptor talking, looking for the high. If you blockade the D2 dopamine receptor, you just killed the motivation, right? And the D1 is another receptor. So there's an array of different receptors, and depending on the receptor, you get different effects from the same neurotransmitter. So that's why one of the reasons that the whole monoamine hypothesis of depression, you don't have enough serotonin, is pure marketing department silly talk. And every scientist knows that. But patients are still being taught this garbage anyway. Don't get into a fight with a psychiatrist about this. It isn't worth it. But I want you to sort of get the sense of this. Benzos, these are GABA agonists. GABA is the main inhibitory neurotransmitter in the nervous system. And what these benzos do is they increase the functionality of the receptor for GABA. So here's GABA. It's a neurotransmitter molecule. It docks with this receptor. The receptor pops open and it lets chloride ions go into the cell. We'll talk about what that means, but that inhibits the cell. So GABA inhibits GABAergic activity inhibits cells from firing. It pushes them away from firing threshold. Benzodiazepines increase the effectiveness of the GABA molecules by about 50 times. So they're very high-powered sedatives. You take 1 milligram and it knocks you. Take a half a milligram of Xanax and it knocks you down. Enough to get on the airplane and go fly somewhere if you've got airplane phobia. Very dangerous chemicals. I'll skip the monoamine oxidase. Everybody else does. So the problem is that with the drugs, and the reason that you'll hear a lot of patients say that they feel like they're being treated like a guinea pig, some patients tell me their psychiatrist says, well, which medicine do you think you should try? And it's like, what? And at least that's an honest psychiatrist, because you know what? They don't know. They're going on clinical experience. They gave somebody some Prozac and they said they felt better. So you sound like them. So you're going to get some Prozac. Somebody else, they give them something else. But it's clinical experience. It's not good science. It's something, but it's clinical experience is better than nothing. But yeah. Problem is there's so many chemicals. There's like 100 different transmitters, and changing the sensitivity of a receptor for one of them, it's a nonlinear dynamical system. You don't have a clue as to what it's going to do in a specific individual. Here's why. Just do a thought experiment. Imagine you must have had some high school or college genetics. You know, there's such a thing as a dominant and a recessive gene. So imagine, and the dominant gene is a capital letter and a recessive is a small letter. Imagine that there are just 3 genes, and there's no doubt a lot more. Imagine that there's just 3 genes that completely determine the effect of Prozac on a person. But imagine that the dominant form of these genes, right? The dominant form confers the ability to react very positively to Prozac. And the recessive form, the lowercase letters, confers the ability to react very badly to Prozac, to the very same molecule, the same drug. And further, just pretend, bear with me here, pretend that for you to have a really great response and feel a ton better when you take Prozac, pretend that you have to have all dominant copies, a copy from your mother and a copy from your father of gene A, B, and C. And that's about what you see. There's this little tail of the normal distribution where there's a group of people, for certain, there's a group of people who, I mean, they say amazing things. They say things like, is this how normal people feel? I can't believe it. I've been taking this stuff for 2 weeks. My doctor said it might take 4 to 6 weeks to have its effect, but I mean, I've never been so relaxed. And I mean, I guess this is normal. Does everybody feel this way? I mean, I've heard that from people. There's a book, Listening to Prozac. It came out when Prozac came out 25 years ago. Creates great effects in a small number of people. In an equally small number of people, it creates an absolute, abject, miserable state. I've had people in tears saying, I started this stuff. I got it on Friday. I took it over the weekend. I'm seeing you today. It's Tuesday. I feel like hell. This is terrible. When does I stop taking it? I said, make sure you call your doctor and talk about it. How long does this take to wear off? I can't stand it. I feel like I'm walking around in hot 10-inch nails and bare feet. I'm 2 feet off the ground. I'm so nervous. I've had that from people on the same drug. So there's huge individual differences. And unfortunately, what the research says is that the vast majority who, let's just pretend, have some mixture of dominant and recessive combinations of these 3 genes, the vast majority, the 70, 80%, you know what? These drugs don't do anything. The average treatment size effect is around a 0.23, Cohen's D of 0.23. The effect size, when it gets up to around 0.8, is considered moderate. So 0.23. The placebo has a 0.20 effect. On the average, in group studies, these drugs, the so-called antidepressants, they really don't do anything for depression or anxiety, except for these little populations that they either really, really help or really, really hurt. That's worth just noting. And then there's usually side effects. A lot of them have anticholinergic effects. We'll get to that. Dry mouth, dry eyes, dry other things. Weight gain is common, digestive problems, sexual dysfunction, headaches, dizziness, and nausea, to name but a few. And so, yeah. Oh, toxic. Somebody posted a chat, toxic psychiatry. Yeah. Frightening. Oh, your mom's a psychiatrist. Please don't get into a fight with psychiatrists, whoever's mom is a psychiatrist. Crap. Now that I shot my mouth off. But look, I've worked with plenty of psychiatrists, and the honest ones know that they don't have a real good, clear shot at knowing what they're doing, because they don't have a way to measure it. They don't have a way to assess your brain chemistry. And so, like I said, I play psychiatrist sometime. I'll call up a psychiatrist and tell them what I think they ought to prescribe. And especially if I have a brain map on you and I know what the heck your brain is doing electrically, I can take a real good guess at what medicine might help you acutely, right? Real good guess. Not perfect, but decent. Yeah. So, yeah. As a clinician who doesn't prescribe, I think it behooves you to become familiar with the medicines the person's taking, what it's supposed to do, what the common side effects are. I think it's a good idea to be empathic and encouraging and tell them to give, no, your doctor is not treating you like a guinea pig. Your doctor is doing the best they can to prescribe a medicine that they think might reduce your symptoms. And emphasis on reduce your symptoms, not cure your depression, not eliminate your anxiety disorder. I mean, if you have obsessive compulsive disorder, you might feel a little bit better on certain versions, varieties of the SSRIs, but that's not going to eliminate your OCD. Okay, it's going to clamp it down a little bit and maybe make you less miserable. Surely, if somebody's telling you that they're having terrible side effects from a medicine, you got to tell them, call up your doctor today, get the nurse on the line, get somebody on the line, and tell them what's going on. You obviously have to be very careful. You are not legally able to prescribe, and you are not legally able to unprescribe. So whatever you do, don't ever tell somebody to stop taking a medicine, right? I don't even support people stopping, like when they tell me I stopped my medicines, I say, did you talk to your doctor about that? No. Okay. Well, I can't tell you what to do, but I can tell you what to do. So call up your doctor and tell them why you stopped these medicines, right? So you want to be supportive, but be careful about prescribing or unprescribing. Specifically, the thing is, you got to get the person to think of the medicine, whatever medicine it is, as a tool that might help with certain symptoms. But tell them to look at it as a temporary tool. And I hope that you don't know any psychiatrists who are in the business of telling patients that they're going to have to be on these drugs for the rest of their lives. I've had patients tell me that, their psychiatrist has told them, well, you have a chemical imbalance and you're going to have to take this medicine for the rest of your life. It's like taking insulin if you're a diabetic. And that's a crock, okay? That's a sales pitch. I'm sorry. That's not true, okay? So you don't get your patients into fights with their doctors, but you want to gently encourage them in the idea that, well, these medicines may modulate things in a certain direction, and if it feels better with that happening, that's a really good thing. Now, here's the deal. Your medicine's going to stop working. They all stop working, which means your brain adapted to it. And so what we want to do while it's working for you is, let's get some cognitive behavior therapy done. Let's get some problem solving done. Let's get some desensitization done, so that gradually you'll feel it. You'll get more and more in charge, more and more in control of how you feel and what you do. And you'll need the medicine gradually less and less. That's our goal together. So that's kind of how I talk to people. And I use psychophysiology every day. When I'm in person, I have all kinds of instrumentation. I have some people that, some of my patients they're now getting home versions of the equipment so they can train at home, and I can supervise them over Zoom. But even without instrumentation, just teaching people to slow their breathing down, right? It has beautiful anti-anxiety effects, just doing regular, easy, slow breathing. You coach a person in how to do that. Putting people up, cognitive behavior therapy means putting people up to creating attainable goals and getting some constructive, useful behavior going and achieving some attainable goals. And that's an antidepressant. It's a gangbusters antidepressant. So, yeah. So that was what I wanted to mouth off about tonight. Thank you for your tolerance. I see everybody's still here. My goodness. Okay. So, so now you know how to, you have some ideas. Read the book if you haven't read the first 2 chapters. Read them. It's not a bad historical, the first chapter is a historical rundown. And so, you know, read the first couple of chapters and then go on the discussion forum and tell me how you will use something that we just went over in your ordinary practice. Unless some of you already have ideas about that. Any ideas about that?
Well, I have a particular client who is having a lot of issues with insomnia, so I got some ideas now from even tonight's class.
Oh, good. Okay. Good.
Like she just called me after like 4 months of nothing and be like, I have insomnia. I'm like, okay, we'll talk on Thursday. So this was well timed.
Oh, wow. Excellent timing. Excellent timing. Yeah. There'll be a lecture on sleep with a lot more on what's called sleep hygiene, which is a funny word, but I don't know another word that sums it up. But the idea of the biggest idea, if she have trouble falling asleep in the first place?
She does. She definitely has very high anxiety, and the anxiety is playing into not being able to sleep.
Yeah,
of
sure.
course, she presents it as I have depression and I can't fall asleep and don't want to get out of bed, but it's more tuned to anxiety about situations, anxiety about what's going on in her life. I can anxiety everywhere.
Yeah,
go on about that.
yeah. So there's good research, you know, I mean, decades of it showing that you know, more anxious people get worse sleep. It's kind of obvious, but if you want to be a scientist, what you do is you find obvious stuff and publish it. Yeah, it's true. Well, I mean, all the good stuff in psychology, once you read the research, makes perfect sense, and it's like, oh wow, I'm glad somebody thought of that. But that's what you do as a researcher. So the thing is, 2 things. You want to. I'll give you an idea right away. I mentioned slowing the breathing down, right? Let me pull up an app. Does anybody have this app? Get it?
I do not. What app is that?
This is called Calm. CALM. So when you light it up, okay, it looks like oops, go away.
Headspace is another really good one.
Headspace is good. It's got a lot of meditation stuff in it. I don't know if they have do they have a breathing pacer in Headspace?
I just use the meditation
Okay.
formats of it, so I'm not entirely sure about the breathing.
Okay. So, well, yeah, I mean, get them both, but don't pay for anything. Don't ask your clients to pay for anything unless you know that money doesn't matter to them. But it looks like that. It's called Calm, and when you light it up, it will it'll go to a screen that looks like something like this. But when you first install it and you first light it up, they're going to try to sell you stuff. So you look in the upper left corner, there's going to be a little X up here. So you hit it, and the X out of that screen, it will give you 2, or maybe it's 3, I forget, front pages that look like this, but they're not this. They're asking you to sign up, subscribe, register. You don't have to do any of that. Just X out of those screens. This is what I tell my patients. And you get to this one, and then down in the corner here, I'm telling you all this because you all might as well get this right away and start using it. Right down here in the corner, it says more. And you press that, and it goes into this. And right in the middle of this is it says breathing exercise, okay? So you hit that, and it asks you how long you want to do it for. I have it set on infinity. I want to keep breathing indefinitely. So then you hit the start breathing thing, and that's what pulls this up. Now this defaults to a speed of 6 breaths per minute. And that's not an accident. That's psychophysiology. These people know what they're doing. For most people, if you're taking about 10 seconds per breath cycle, it's 5 seconds in, 5 seconds out. That's 10 seconds per breath cycle. That's 6 breaths a minute. For most people, that's going to be the easiest, most relaxing kind of a state. For reasons that escape me, the thing, when you first start it up, it defaults to this pattern. And this would be inhale, hold your breath for several seconds, and then exhale. I find that unnecessary. I like this one. There's another one, which is inhale, hold your breath for several seconds, exhale, hold your breath out for several seconds. I find that completely awkward and unnecessary and contraindicated. That's yogic stuff, and without a yoga instructor, I don't like messing with that. So I like to use this one with my patients, where it's very, very simple. It's easy to relax into. And this is just a pacer to get the person used to the idea. You got to get them non-competitive with themselves, but just an easy breath, in and out, and you get them to practice that. And so then here's the kicker. You may have heard of conditioning, operant and classical. You may have heard the term that heard that we're creatures of habit. Guess what? We're creatures of habit. You did you today the same way you did you yesterday. Didn't you seem familiar to yourself today? Of course. All of the things in your environment remind you to act the way that you usually act when you're around those things. And it's called conditioning. It's called discriminative stimulus in operant conditioning. It's called the classically conditioned stimulus in classical conditioning. But the fact of the matter is your patients and you do exactly what they do every day. You do more or less, you do yourself the same way. You breathe the same way. And all the stuff in your world reminds you to breathe that way. So guess what you have to do? You got to get rid of this mistaken idea in psychology, in counseling, that talking about it is going to change things. Talking about it isn't going to change things. Let's talk about playing the cello, shall we? Anybody get really good at a musical instrument by talking about it? I haven't heard about that happening. Have you? Seriously?
Choir.
Huh?
Choir.
Choir?
Yes.
Thank you. There. Now I can sing beautifully.
Yep,
no.
exactly.
Yeah. Do, re, mi. No, you don't want to hear me sing. Now, I got a synthesizer back here. That's a different story. It sings much prettier than me. But if I wanted to sing pretty, I got to practice these patterns over and over and over again, don't you think? See? So when you're treating patients in your office, what you got to be doing is figuring out what patterns do you have to talk them into practicing at home and at work and elsewhere. What patterns do you have to get them to practice so that they start feeling better, so that they start feeling more in control, more empowered? And so what you have to do, see, you see that that white thing over there? Right? That's the door out of this room. And it's closed right now so that you don't hear my barking dog or my 9-year-old unless he starts thumping on the ceiling above me. But when I walk over to that door communicates to my automatic unconscious habit-driven brain. And what it says is, it says, open me. Right? I bet your doors say that kind of thing to you too, right? I mean, I don't hear it. Don't worry about me. But the door, when you walk over to it, says, open the door because you're done here. But now watch this. Watch this. It's pretty far away in this camera. Can you see? I just put this pink Post-it note on the door. And I made a little agreement with myself. Oh, I changed my world, by the way. Like, changing me is a real piece of work. But, and therapists make this mistake all the time. You think you can change people, or you think they can change themselves or something. I don't know. It's crazy thinking. What you can do is you can put the person up to changing their world. It's very, very easy to change the world. Did you see that? If you can see that little, it's pretty small from how it looks through my camera on the screen, but there's a little pink Post-it note on that door now. So that is no longer a white door, is it? I changed it into a white door with a pink Post-it note on it, which, when I leave here, I might actually notice that, right? And so if you made an agreement, if you got your patient to agree that they would put pink Post-it notes up on their bathroom mirror and on several doors and on lamps that they turn on, and on stuff that they use, maybe a dozen of them. And if you got your patient to agree that when they see this pink Post-it note, they will stop in their tracks. That's important. This is not just a reminder of, oh yeah, that'd be good for me if I breathe slowly. No. And then walk on? No. You got to get them to agree. Get this woman, Michael, that you're talking about, to agree. Get her to slow her breathing down. Pull up Calm on your phone. Sit there with her. Get her to just relax her upper body a little bit. conduct. I like to conduct, right? Breathe out now, nice and easy. Now just take an easy, slow breath in. And then breathe out 1, 1,000, 2, 1,000, 3, 1,004, 5. Breathe in. So just pace, conduct, right? If you do that, I bet that in 2 or 3 minutes, if you say, now, what do you feel like right now compared to right before we did this? 90% of the people I've ever done this with, they will say, oh, I feel a little more relaxed. And so then I go, you do? Wow. So that was easy. You're kind of stirred up and anxious and you have trouble sleeping. And yet I showed you this little thing and in a few minutes you felt more relaxed. You noticed it. Good. What do you think would happen? What do you think would happen if you practiced something that simple, let's say 100 times? And usually the person will say, well, I guess I'd get good at it. So yeah, you would. So how about if I could get you to stop in front of a pink Post-it note, maybe 10, 15 times a day. I actually usually shoot for 20, and then they might do 10, you know. You get them to agree with you, make a strategic alliance about this. You get them to agree, you know what, this is important enough that I'm actually willing to put Post-it notes up, and I'm actually, or some kind of cute stickers or something, that for a week or two, I will do my best to stop in my tracks. Like when I leave this room tonight, I don't have to just go charging through that door. I really don't, right? I could stop for a minute, slow my breath down, take 6. I like to shoot for a half a dozen slow breaths. That takes 1 minute. And if I can get a person doing just 1 minute, a pause, just stop your headlong rush to the next thing and just be there. Just get yourself in place. 2 things happen. One thing is, if I get you to do that for a week or 2 weeks and practice 100 times or more, you're going to actually be able to calm yourself down significantly by slowing your breathing down. It'll go fast. It doesn't take long once you know how to do it. The other thing that'll happen is that doors will have taken on conditioned stimulus value. Laptop computers, lamps, mirrors, windows will have taken on stimulus value, which means that they will automatically, without you helping, they will automatically provoke your automatic habit brain to breathe a little slower and to relax a little more, simply because you've practiced relaxing in front of a door or a whatever. So if you do that, that'll help this person start getting into a more relaxed state all day long. If you can get her to meditate for 20 minutes twice a day, that'd really, really work gangbusters. And then tell her, don't lay there in bed cursing the bed and yourself for not being able to fall asleep. If you don't fall asleep within 20 minutes, get out of bed and go do it somewhere else. It's called sleep hygiene. Hang around, do something not exciting, read a book, read poetry, listen to soft music until you're really, really drowsy, and then put it back in bed and see if you fall asleep quickly. If you're not asleep in 15 or 20 minutes, get out of bed and go do it somewhere else. I don't care how late you stay up the first few nights. It's good. You stay up until 3 o'clock. You finally fall asleep quickly when you put it in bed. Guess what? You just paired the bed with falling asleep quickly, and that's what you want, because right now the bed is paired with not falling asleep and with worrying about the consequences of not falling asleep and with getting pissed off at yourself for not falling asleep. And so you got to break that connection and establish the connection of, hey, bed, I'm so tired I can't keep my eyes open. Boom, gone. Normal sleep onset's 5 or 10 minutes. I'll say more about that in the sleep lecture, but that's just because you you have this patient coming in Thursday. That's what to do. It works. Challenge is getting them to do it, but the techniques work.
Thank you.
You're welcome. Other stuff? Any other stuff? Okay. So I hope you enjoy the book. I hope it's not too horrible for you. There's worse books. I almost went for the Handbook of Psychophysiology. It's that thick and it's nasty, but it's really hard to read. I got a copy of it, and so I decided that was a bad idea. But this one's pretty readable. Oh, and I don't know if any of you got, I mistakenly did not highlight the idea that it is available in Kindle format, right? But it's also paperback. So did anybody not get it yet, the textbook? Because, or I guess if you got it in paperback or hardback or something, you just paid more money for it. You could always return it. I just got the Kindle format for it, and it's pretty easy to look at. So well, that's what somebody wrote. That's what I have is a Kindle. Yeah. And there's if I were actually studying this, yeah, that's the paperback. If I were actually studying this for the first time, I would actually want a paper version of it. I've seen some studies saying that people learn better from paper books. I don't know if it's true, but I like how easy it is to flip back to a different page and dog-ear pages and write on them and stuff. And I know you can emulate that in Kindle, which is fine. But anyway, as long as you got the book, and see if you can enjoy it. See if you can take it as a if it's unfamiliar territory for you. See if you can take it as an interesting, intriguing exploration of like, wow, people actually study stuff like this? No kidding. Yeah, it's what I did my PhD in. I did all kinds of EEG recordings and deep trance hypnosis and event-related potentials and crazy stuff like that. So if you're going to go get a PhD, don't do crazy stuff like that. It took too long. Well, I decided I wanted to see if I could take pictures of Freudian repression happening, which it turns out you can do, actually. But it took quite a number of years to do it. But anyway, that's a different story. So, okay. I wish it could be more personal than all of this, but I hope this was interesting to you folks, and I hope you'll feel free to ask questions, make comments, and yeah. I guess that's about it, unless there's any other thoughts.
Question, is the discussion going to be open today until next week?
Yeah.
Okay.
Yeah, it's already posted. It's the discussion forum. You know how to find the thing in Blackboard?
Yeah.
Yeah. Okay.
Thank you.
Yeah. Okay. All right, then I guess, same time, same station next week, and stay safe and try not to expire from the sheer boredom of the whole thing. And yeah, keep yourself safe. And I hope you all have masks of some kind.
We do.
I hope, yeah, make sure you take it seriously. It's a pretty bizarrely nasty bug. So yeah. All right. So see you all around.
Thank you.
Awesome.
You're very
Thank you.
welcome. Take care.